Welcome to the Trauma Preventative Health Podcast, hosted by the Jewish Orthodox Women's Medical Association. We provide you with up-to-date information on health topics geared towards the Orthodox Jewish community. This podcast content is provided for informational purposes only and is not intended as medical advice or as a substitute for the medical advice of a physician.
Everyone deserves to be safe. The Lev Initiative provides mental health support to those impacted by intimate partner violence, also known as domestic violence. We take a holistic approach to help survivors of any age find ways to heal and thrive. Our virtual and in-person services include crisis and individual counseling sessions, support groups, psychotherapy, community-sensitive emergency housing, and linkages to a variety of community resources. The Lev Initiative is brought to the community by the Jewish Board in partnership with UJA Federation. For more information, contact us confidentially at lev@jbfcs.org. That's lev@jbfcs.org or 646-273-1800.
Welcome, Dr. Segura-Harrison. Thank you so much for joining me today.
Yeah, thanks for having me on the podcast.
For the third time. I'm really excited. And now we get to talk about your greatest passion. Well, one of your greatest passions. You have many.
I have many. It's true.
Yes. We're going to talk about family medicine. You are my first family medicine doctor that I'm interviewing about family medicine. So I would start with please telling us, what is family medicine?
So family medicine is a specialty that arose out of the background of the old tradition of the general practitioner. Who did everything, the Marcus Welbys, right?
I loved him.
I never even watched his show. It was before my time. But the old school family doctor taking care of the whole family, getting paid in chickens, that kind of thing, right? Delivering babies, cradle to grave, everything. Hospital admissions, the whole gamut. Modern family medicine really started to take shape in the middle of this century, and is now like a well-established specialty with a board and specialties of its own. I like to sort of determine, like when I'm talking to medical students who are trying to pick a specialty, what is the difference between family medicine and say internal medicine or pediatrics or med peds, is that family medicine does have specialties, but they're usually population-based specialties: adolescent medicine, geriatrics, maternity care. And actually there's been some breaks in that. There's now sort of substance use disorder fellowships, but the vast majority of family docs, even the ones who complete fellowship, still do full spectrum care. And how broad that spectrum is really varies by geographic location, by community, by setting. So sorry, that's some construction noise in the background. Rural versus urban, community health center versus private practice. People do different things. And even though family medicine training is incredibly broad, in 3 to sometimes 4 years of residency, there's variability in training program lengths as well. You get training in taking care of adults, children, and pregnancy care. And how far pregnancy care extends is also a spectrum. Some family docs don't do any pregnancy care. Some do preconception or interconception care. Some do preconception, interconception, and prenatal care. And some do the whole thing plus deliveries and inpatient obstetrical care. And I don't have the broadest possible family medicine scope. I do inpatient obstetrical and newborn care. I don't do inpatient medicine, although I trained at a program that had a robust inpatient medicine component, and I could do that if I wanted. There's just not enough hours in the day.
So what I'm wondering is, it's the same amount of time that you train for family medicine as you do for internal or pediatrics, or OBGYN, right? You said 3 to 4 years. It's putting aside fellowships.
So OBGYN would be all gynecologic or obstetrical care, including surgical management, in 4 years. Internal medicine would be all of adult medicine in 3 years. right? And
Mhm.
pediatrics would be all of pediatrics in 3 years. And within 3 years, how are we supposed to do all three of those things? Is that your question?
Yes, that is my question.
The good news is that most family docs do outpatient medicine as a good chunk of what they do. So we get much more comprehensive training in outpatient clinic than either of those three specialties, because we spend a good amount of time in clinic. We have to do between 1,600 to 1,650 outpatient encounters. And so when I talk with my colleagues who are internal medicine trained, who end up going into primary care, a lot of times they've had, 1 half day of clinic a week or something like that. And they've sort of had to sort of teach themselves the fundamentals of managing outpatients in the office. And that we are really on solid ground after finishing residency. The other component is that we are really taught information mastery and the limits of what we don't know and when to refer.
I think that's a really important point, because, what I'm thinking as I'm listening to you is that medicine has become more and more specialized. And it seems almost going backwards to have a broader approach, but I think it's the other way around, because it's like you said, there's only so much we can know. It didn't make sense to me to have so much training in inpatient if I was going to be an outpatient doctor. So what you're saying is you have much more outpatient training during your residency.
Right. Which is not to say that we don't have robust inpatient training. But folks who are going to do predominantly inpatient tend to spend most of their elective time focusing on inpatient topics. Like I did a dedicated elective block for high volume inpatient obstetrical and newborn care. And I focused my electives on those things, except for my elective in Orthodox Jewish community health, which is another topic for another podcast. There is room for individuation within family medicine training, which is part of, I think, what makes it appealing to people who like a little bit of everything, but have areas that they want to have a little more expertise in as well.
I want to talk a little bit more about what you said before about knowing when to refer, because this is something that I have said I dive in every day before I go to work, that I should know what I know and I should know what I don't know. And I think that if you're expecting yourself to know everything and you can't, right?
Right. So this is a phenomenon that people refer to as family medicine humility. Right. And this is like an idea within family medicine training that we're taught to have a very good sense of when we're out of our depth. And that's part of the precepting, part of like the Masorah of family medicine training, is that, a lot of what we're sort of taught to think about is, can I or should I manage this on my own? Should I involve a specialist? Am I practicing in a setting where there is a specialist available? And we rely a lot on discussing with colleagues. And that's why, even folks who are sort of like in early practice or even mid practice will often consult with their colleagues. And you really are never alone. I still discuss with mentors from my residency days, colleagues from my residency class. There's, I think, a conviviality about the practice of family medicine that is, I don't know if that's unique to family medicine, but it's one of the things I really love about family medicine. Right.
I think everybody should learn, right? Because it's a lesson that everybody should learn, because even if you've done all of this training, the knowledge is changing at this point at such a rapid rate. I don't remember the doubling rate, but it was like every, 5 years at this point. It was some crazy thing. So you can't know everything. And you really need to have humility, even if you are a general pediatrician, an internal medicine doctor, or an OBGYN.
Well, I'm like 8 years out of medical school at this point, and there is so much that just wasn't even a thing. Intermittent use of inhaled corticosteroids for asthma, total game changer, right? There's like in GLP-1s, SGLT2s. These were just coming on the scene, right, when I was in medical school. And now they're talking,
I'm sorry, for people who don't know, you're talking about those new Wegovy,
Ozempic,
weight loss semaglutides.
Right. So, and not just primarily they are diabetes drugs. They're also being used a lot for weight loss, but, even in their routine management of diabetes, there are still, that's still new for a lot of people, especially who've been practicing a long time.
How do you keep up with all this information? Because even to be a generalist, you have to know so much.
I log a lot of time on UpToDate. I have the app on my phone. I reference it constantly. It's like, and I think also like the benefit of doing that, and I will re-reference and reread articles or look for a particular algorithm or graphic, and I'll use it in teaching. I precept one afternoon a week, and I have medical students in my clinic. So I think that's another benefit of this, is that like when you're teaching, you're always relearning.
Mm-hmm.
So I think teaching definitely helps me stay current. I'm also not that far out of training. I'm about 2.5 years in practice at this point. So there's that, but I think it's really like continual information mastery, right? There's CME, and then there's like daily CME.
Right. You have to know. It's because you know you're not passing a test or meeting criteria for your certification. It's because you have to know.
Right. But there's also this sense that you don't have to know right away, right?
Mm-hmm.
Family medicine is built on this model of longitudinal care over time,
Mm-hmm.
right? You see someone in the office, it's not the only time you're going to see them, right? And it's okay to say, I'm not exactly sure what to do. Let me consult with a colleague, talk to a specialist, do some more thinking, right? And I will bring up UpToDate in the exam room with patients who are often very happy to do that. Like they feel like they're involved in, me thinking about their care in a really involved and deep way.
Right. If you think about Marcus Welby, like that's the old model of the paternalistic doctor who always knows best. Medicine will call the doctor knows best, right? And now we're doing more of a collaborative care, and patients come in often with a ton of information at their fingertips too, by the way.
Right. I mean, it really varies, and it varies who you're taking care of. But a lot of my patients, even ones who don't have like very extensive medical knowledge, have a lot of opinions and feelings and thoughts that are very valid about their illness and their disease process. And so part of the collaborative care that I want to provide is also to involve and integrate my patients' goals, ideas, thoughts, priorities, feelings, cultural context, family, right? All these things are really important to me.
How much time do you have for patients? When you want to start talking about social determinants of health and collaboration and all that stuff, I want to know.
I happen to have a better setup than most family docs. I think I have 30-minute visits across the board.
For new patients too?
For everybody.
You don't get longer for new patients?
So I don't. New patients will often take longer, but not every sore throat will take 30 minutes either.
I see. So you make it up then.
Right. So, but every patient is blocked for 30 minutes, and I have one overbooked televisit slot. That is not common. I would say that I practice in a really unique setting, which is a Cambridge Health Alliance, which is like a lovely health system a little north of Boston. Cambridge, Somerville, Everett, Malden, Revere, and there's Winthrop, something else, whatever, that area. And they are like lots and lots of family doctors and internal medicine and pediatrics and OBGYN and some in-house specialists. But it's really very sort of primary care forward. And that's sort of the setup that I've been, is my first and hopefully my permanent, like for post-residency setting. And I feel like I'm really lucky to have so much time with patients.
Right. Do you have other, not to say specialties, but other disciplines that you work with that you can refer to, say like a therapist, a social worker?
Yeah, we have integrative behavioral health within our clinic context. And
I'm so jealous.
It's so great. I love it. You come work
what I would do for that. I want to move.
It's great. And we have pharmacy, like our pharmacotherapy team. And they do a lot of our routine diabetes, hypertension management, and especially the ones where it's iterative, right? You start someone on a med, you're titrating, you're seeing them back. And so they'll send me all of those visit notes, and I'll review them, and I'll discuss with the pharmacist, and we'll sort of go back and forth. And the patient really feels like they have a team approach, and we're all up to date, and we're all, on the same page about their care. And same thing with diabetes med titration and glucose monitoring. And that actually I really like that, because I think it sort of takes that, like I know how to titrate someone on insulin, but it's not my most advanced skill in diabetes management. And I feel like I really like being able to sort of see that process, set up that process, see it happening. And like with someone that I know is like a real expert in it and does a really good job and has phenomenal patient rapport skills. And then, I check back with them and they're like, oh, I did this with the pharmacist and I feel really good about it. And they taught me all these things, and they're getting like there's a significant value add from working in a team like that.
This is fantastic. And it also helps like the idea of, well, you can't know everything, because all knowledge is not just stemming from doctors, or there, people in that level of, those practitioners.
Right. And like
also,
the pharmacists will often suggest, like, and they're like, and there's actually like, there's a new med that just came out. It was like on the new, like up to date, like now best practice. So let's say this is a deep dive in some adult medicine, diabetes for a moment, if you'll allow it.
Sure.
Right. So diabetes often comes with diabetic kidney disease, and that's something we screen for. We screen for protein in urine. When someone has protein in urine for years, like ACE or ARB, and it gets bad enough, send them to nephrology. And there's now another tool in our tool basket, right? There's a med that's sort of a relative of spironolactone that is shown to be renal protective after a certain GFR has been reached or fallen to, I guess, that is protective, and people should start it. And so like, and I missed the memo on that one. I didn't know about it until my pharmacist was like, this patient would really benefit from this drug. And I was like, oh, look at that, like a new thing. Right. And especially that's like the benefit is that there was something I didn't know. Someone on my team brought it up, and now I know something new.
That's fantastic. What would you tell lay people listening to this? Because this podcast is really geared primarily to lay people. I mean, this is sounding to me more like our specialty spotlight episodes.
Yeah.
Which is fine, because
yeah.
I also do share this with physicians and physicians in training and other healthcare.
Yeah, but let's talk about the patient value add. Yeah. So I really think that there's a lot to be gained from the family medicine model for the patient, right? Because I take care of whole families, right? So and that can be, families look like a lot of different things nowadays, right? Families can be grandparents taking care of kids. Families can be parents and children. Families can be a couple. And I love Ellen Satter's, one of my favorite nutritionists, says that whenever you decide, I love Ellen Satter, but she says, whenever you decide to take care of yourself, then you're a family, right? Whenever you're caring for somebody, even if it's just yourself, you're a family, right? So, like my job is to take care of families. I'm getting a little emotional because I'm a pregnant lady. My job is to take care of families, and whatever that means to the family that's in front of me. And that means like I'm paying attention to what's the cultural context of this family, what's the religious context of this family, what's important to this family, what's this family going through, right? And what's the dynamic in the family, right? And these are all things that are inseparable from illness, health, well-being, daily life, right? And every family doctor is like a little bit of an anthropologist as well, right?
I love this.
Right, because you have to sort of be really intellectually curious about what other people's experience of life is. Right.
It's so important, because I mean, how do we how can we stand there like the doctor knows best and tell somebody what to do when we don't know anything about their lives?
Right. And so like part of what I try to do is try to get to know people's lives and people's lived experience, to try to partner with them in optimizing their health, if that's their goal. Sometimes their goal is not optimizing their health, by the way. Right. And I feel like we have this like healthist perspective. But sometimes patients have other priorities, right? Sometimes it's, and sometimes that's like subsumed under the larger goal of health. Sometimes it's substance use disorder recovery. Sometimes it's being reunited with their family who's in a different country, right? There's other goals and priorities the patients have. And to miss those is to be inattentive to something that's hugely important to them.
Absolutely. I heard a podcast where they were talking about states. They said, instead of talking about weight, we talk about body state. And that sounds like it's just like a semantic thing, but it isn't, because you said some people want to focus on their body state, but other people aren't interested in that. Their mental health state is more important to them, right? Mm-hmm. Or some other state that they are living in, and they get to pick which their focus is going to be, which makes so much sense.
Yeah. And I think that like, that's part of like in a medical ethics framework, respecting patient autonomy
Mm-hmm.
is part of, like, that's part of the basic goal there, is to really identify, like, what's the patient's priority in this setting. Which is not to say that we should be doing things that are harmful to patients. That is,
Right. It's not like I have it your way. We're not talking about
right.
that.
It's not, yeah. But it really is, about sort of that deep understanding. And then I think the value added family medicine is that, like, that is, I think, something that is, like, very much part of our training, but also the fact that it's integrated care, right? So and this is, I think, particularly germane to family medicine obstetrics, right? I do prenatal care. I guide my patients through preconception, conception, prenatal care, in hospital care, delivery, postpartum, hospital discharge, and and then mom and parents and baby come back to me together, right? For those, it feels like they're every day. Like, I don't know, it depends how feeding is going, but, like, sometimes it's every day in that first week home from the hospital.
Wow.
Right. Or every 3 days, every week, right? And there's a lot of touch points. And if it's the same person or the same team, that just gives you a better sense of what's going on and how to help.
So do you work with families that you are their only doctor, or do you see who's ever on a panel? Like, how does it work?
So I have families, entire families on my panel, where I see both parents, all the kids, sometimes the grandparents, sometimes the sister-in-law, and I have families where I have 2 out of 4, and then my colleague has the other 2, and that sort of, like, when they joined the practice, that they weren't taking new patients, or whatever it is that it happens, or I'm a better fit for someone in their family, or there's a teen girl who wants a female doctor, right? So, and there's some flux, right? So, like, I work with a lovely team of doctors and PAs, and we have panels that are set up, like, with the PCP, and then team PAs that work with multiple doctors, so that there's always more than one person that knows about each patient. Because inevitably, like, we go on vacation, we go on maternity leave, like,
Right.
Someone's got to know what to do.
Right. Because you're offering continuity. So you want to make sure you have that.
So that's a lovely way to have continuity. And we have within that groups of doctors and PAs who are teams. Right. And so I have some knowledge of, like, a bunch of other people on my team. And then within that, there's also prenatal teams. Right. So me and one other doctor will be the ones who most often see some chunk of our current pregnant panel, right? Because there's, like, a list of all of our prenatals. And then another 2 doctors will see, like, the other half, but, like, we'll also sort of, like, cross-talk between and review each other's charts and sort of generally be aware of what's going on.
That's fantastic. Can you walk me through a typical day?
Yes. You know what? Let me pull up my schedule. It's so different day to day that I
while you're doing that, I also want you to think of who do you think would be a good fit for this career. So I'm doing specialty spotlight at the same time. I'm multitasking this talk.
That's good.
I'm not going to get you anytime soon.
Are you sure you're not a family doctor? Because we multitask all the time also.
Pediatricians are pretty similar, let me tell you.
Yeah, it's true. There we go. Yeah. I actually started out in OBGYN.
Mm-hmm.
So I did a year of OBGYN, and I didn't love surgery as much as I thought I did initially. Loved delivering babies. Didn't love doing hysterectomies or scrubbing on hysterectomies. I didn't actually do a hysterectomy as a first-year OBGYN resident. And I loved outpatient GYN. I loved the office. I loved contraception and procedures. I did not love being in the OR. And that is a necessary prerequisite of being an OBGYN, is that you must love the OR. Or you become an MFM.
Yeah, but I think also but I think also you love looking at the whole family. You can't do that.
Right. So I became a lactation counselor when I was in medical school. And I was, like, really championing, like, breastfeeding and infant feeding and all these various forms. I did infant feeding research, and then I was like, wait, this is not really so spotlighted here. And I was like, wait, there's another venue in which I could do more of these things that I like. And also the part of gyn-onc that I really loved was palliative care. And I was like, how do I get a job where I'm doing lactation, but also sometimes palliative care? And I was like, I know, I'm in the wrong specialty.
Right. You need to do it all.
Right. So that is what I did. So I left my OBGYN residency and I rematched for family medicine. Let me show, I'm pulling up my schedule. All right. So what did I do what was I doing Wednesday? Wednesday was a particularly long day because I had night clinic. Right. So Wednesday I had a televisit starting at 8:40. And then I had in-person visits until about 1. And I had my medical students with me, first year medical students, for that session. And so we saw 2 new adult patients, 2 prenatals. We did a pessary care visit for urinary incontinence. We did hospital follow-up. We did, that was my morning. That was my whole morning. And then I had a chunk of time in the middle where I did administrative work, right? So I signed some prior authorizations. I filled out a form for a special formula for one of my littlest patients with a milk soy protein intolerance who needs an extensively hydrolyzed formula. I wrote some result notes. I signed some controlled substance refills. I have a very neurodiverse patient panel. I have a lot of patients with ADHD, sensory processing differences, autism, and I really have like I have many passions. I have a mini passion for taking care of neurodiverse folks in lots of different ways. So like that's like part of one of the cool things that I do. And then so in that break, and I then went home and cooked dinner for my family. And then I ran back to clinic. And I had patients from 4 until 8. And I had 2 well child checks, a televisit about diarrhea, which was lactose intolerance, a sick visit for a sore throat, 2 new patient established care, and some follow-ups for new diabetes, and some follow-ups that were just routine physical exams, but ended up being so much more. I diagnosed a dental abscess, and I was assessing someone's eating disorder, and I gave the okay for someone to start stimulant treatment for their ADHD that their psychiatrist is managing, actually, not me. But there was a lot of sort of integrated care. So that was a all clinic day. Do you want to walk through a hospital day too?
No, it's okay. Because that was very detailed. That was good though. But people should be able to see that it's very diverse. And on a hospital day, you might deliver a baby, right?
Right. So I'll go in, I'll round on postpartum patients and babies. I'll discharge whoever's going to be discharged. If someone comes in labor, I'll take a break to evaluate them and sort of get them a plan. Send them home if they're not really in labor, get them admitted if they are in labor, set up their plan for what we're doing next if they're in labor, deliver them if they're actively delivering, round on the rest of the patients. And that's sort of like the main work of the day. And then whoever comes in, if the other services are really busy and we're not, we may help them out by managing some of their patients. It's anything can happen.
Right. But also it's a lot of time because you're spending a lot of time per patient. I just want to point that out.
Yeah.
Right. It's a lot of time, but it's not a high volume. Probably like 16 to 20 patients a day during clinic.
Just about 20 patients a day-ish. Right. Yeah.
So that would be on the low end. Yes.
Yeah.
Yes. Right. A lot of doctors are seeing 4 to 6 patients an hour.
Yeah. Yeah. There are family doctors who see 4 to 6 patients.
Sometimes 8 or more, it can be very, very quick. So now my next question is,
that wouldn't really work for me, I don't think.
Right. So you're working in what we in the New York, New Jersey area call out of town.
Well, I mean, like that works for me also because like I don't want to have to wear a suit to shul on Shabbos.
No, but what I'm going to ask you, is that do you see this as a model for the in-town type communities, and if so, how?
I mean, well, I hope so, because I think it's better care,
Mhm.
right? I think it would be really nice if the in-town communities could somehow pull this off.
Mhm.
And I'm wondering what the barriers are to like propagating it there.
Money.
Money. Yeah.
Right. I mean, you have to get reimbursed enough.
Yeah. I mean, I think that that's actually sort of the model of a community health center, is that there's other specialties that reimburse more. And so, but if everyone gets paid sort of roughly the same amount, then you can kind of make up the difference.
Mhm.
Right. The other thing is that I also do a lot of procedures. So I think my clinic reimbursement is probably higher, or I hate this like part of medicine,
Right,
but
right,
like,
right.
if you do procedures, for some reason, our fee for service system like thinks that that's more important than like
Right.
talking to someone about their diabetes, which I personally disagree.
Preaching to the
I
choir
think,
here.
yeah. But like if I put in an IUD, but often when I'm putting in an IUD, I'm also talking to someone about their diabetes. So there's that too. So there's a lot of value that we can do in longer visits. So I wonder if, health systems would think about that for a minute and see sort of if there's a value add there that could make it sustainable.
Right. I mean, also, if you know the whole family, and it's a large family, right? Like you talked to me about possibly seeing
Right.
like a
Oh,
whole
this
family.
idea for group visits, right?
Hmm.
So I had this lovely idea, a dream really, that we could do group visits for large families. Like well child visits where like the whole family gets their well child checkups and the grown-ups get their grown-up checkups, right? And wouldn't that be nice? And wouldn't it save everybody so much time? And couldn't you talk to everybody about healthy eating? And couldn't you talk to everybody about limiting screen time at the same time?
Right. Because
Um,
those are all family things anyway. It should
those are
never
all
be
family
focused on one
things, right? You're
individual.
not going to be able to get, you know, everybody on board unless everybody's on board.
Right. Right. It's economy of scale.
Right. So if you could, and also in our community, like large families are kind of like expected, right? So say you have like a 6-person family, that's like a moderate sized family in our community, right? Even if you had like a 4-person family, right, and you're talking to everybody, over the course of like an hour, right? That's still 20 minutes per patient, right? And you're probably able to do a more comprehensive job.
Right. And with even larger families, you have even more economy of scale.
Right. There's
It's
more
not too
economies of
overwhelming.
scale.
Yeah.
Right.
That's just the day we all go to the doctor. I mean, it
Right.
makes
And if
so
it's,
much
an
sense.
8-person family, you may need 2 hours. I'm just saying.
Right. No, but still, you
Yeah.
could still do it in that same, it doesn't have to be an assembly line.
Right.
I've also heard the idea of bringing in multiple families together for education. So the educational piece of the visit would be one evening where everybody learns about healthy eating and stuff like that.
Yeah. I think that might be a little more difficult because then you're like dealing, like, I think there's like general things you could do, but the specific counseling, like where it's like, well, what are you guys doing? What's working? Let's troubleshoot. You can't really, it's harder to do in a group.
Right. You can't individualize it, but then you can at least take the background for granted. You don't have to start from the ABCs.
Right. What I really like is the idea of group prenatal care, which we haven't yet been able to implement in my clinic setting, but I had some exposure to in my medical school years, which is where you have, like a cohort, like a due date club, right, of pregnant patients who are coming together. And like the medical piece of it is sort of handled, right? Everyone gets their blood pressure checked and some everyone, when we used to do universal urine dips, which is like, I'm showing my age because people are not doing that anymore at every prenatal visit, but that used to be part of it. And then really a lot of it is like community building, right? People are like talking about discomforts of pregnancy, like have heartburn, I'm tired, and like people are like, yeah, me too. It really helps to take a nap in the middle of the day if you can, or even just close your eyes for a second. That's the kind of advice that you get from other people who are going through it.
Mm-hmm.
And it really like sort of breaks that hierarchy right down, and people can really feel comfortable and also engaged in, but also empowered by their care.
Right. It's like the best of the support group and the medical knowledge together, because instead of support group, sometimes you'll get misinformation or just, guilt that you don't need, that the doctor could help with. And then the other patients can make it more, with realistic tips.
Yeah.
Practical tips.
One of the PAs on my team actually runs a health at every size wellness group. I wish I could be in that group actually as a patient, because it's just so great. And they like there is group wisdom to be found
Right.
there.
Right. And also, you picked a very sensitive topic for me. You know that I'm very focused
Yeah.
on this right now. Could go talk about that all day. But
Wait, that's like a different podcast. We have to
that's
like, limit it to one
I've done many
per
podcasts. I've done
Yeah.
many podcasts on, so you say health at every size, and you're really talking about the non-diet approach to weight and nutrition.
Yeah.
Right. And
Or
I
to
think
like wellness and wellness, nutrition, movement, like, yeah.
right, to everything, right? It's not just
Everything.
about nutrition, because it's also about exercise. You could do exercise to intensely to lose weight, or you could have that joyful movement that makes
Stress
you feel
reduction,
good.
sleep quality, cardiovascular fitness. There's
Mental
many other
health.
metrics to
Right.
pick. Yeah.
Right. And so there's so much that you cannot get into in even a 30-minute visit where you have to do a lot of other things, let alone a 10-minute visit when it comes to all these things, all these wellness.
I mean,
It's so
when you
important.
just think about routine health maintenance for an average healthy adult, every screening, every mental health screening, every substance use disorder screening, every social determinants of health screening, like there was a study that said primary care docs would need 27 hours a day to do their job.
I've heard
Right.
that.
So it's just impossible. And so like the only way to do it is to break it down over multiple visits. Right. But there's also this pressure of like, you might not see that person again, especially if they're young and healthy and aren't going to come in for something else. Which is why I tried to get, as much primary care done, as much preventative care done in every visit if I can. But sometimes it's not the priority, right? And the patient has to tell you what their priority is.
Right. It has to be the patient's priority. But the sad thing is when it could be their priority, but you have so many other priorities of your own, you don't get to it. Or you don't get to it adequately. You want to just do lip service and be very superficial.
Right. There's also like this huge piece of it, which we haven't really talked about at all, which is that primary care works up undifferentiated illness.
Mm-hmm.
Right. Right. That is actually like the most fraught and bewildering piece of primary care, is that you have this thing that, and I saw this like bumper sticker, and it was like, working up undifferentiated illness takes courage. It's like a very family medicine specific bumper sticker. I don't know who they were thinking would use it.
Oh my gosh. What do you even mean? You need to explain this more.
Right. So, I got it at the Family Medicine Educators Conference. Right. And it was like a sticker to like put on your phone or computer. And it said, working up undifferentiated illness takes courage. Right. So someone comes to you and they have something weird going on, right? Their body mysteriously hurts for no good reason. They have some kind of weird rash, right? Won't go away. They feel tired all the time and it's not clear why, and the labs aren't really showing why. And it really takes, either illness process is going to declare itself over time, or it's going to get better, or you're going to figure out what it is and fix it. Or if you can't fix it, you're going to help them sit with it.
Not just that, but if you're talking about things like fibro or long COVID or chronic fatigue, those all POTS, a lot of these are disorders that if you say work up, they may not have markers. They're just as real.
Right.
So,
but it doesn't mean they're not real, and it doesn't mean the patient's not suffering.
Right.
And so I think there's like a lot of work to be done to have the courage to kind of sit with the patient with things that are not fully characterized. And may never be fully characterized.
Right. That's why I didn't like the working up part of that bumper sticker, because I think it's not the working up, it's the being with them on the journey.
It's the working up and taking on, right?
Taking on. I think taking on would be more accurate, because the biggest mistake is they go from doctor, especially in our hyper specialized medical world, they go from doctor to doctor to doctor. Everything's negative. They're very frustrated and they're not getting better. So to sit with them and to see, well, I may never get a specific answer to what's wrong with you, but I'm going to help you feel better now.
Right. But I think part of what I do is set the expectations that I may never be able to do that.
Right. You should.
Right. But I'm still here with you along the way.
But I think also it's really important to also say, I'm going to help you look as appropriate. I'm not going to write this off as whether or not you say, disparagingly, it's all in your head, or you're thinking that you shouldn't.
Right.
But even if you're thinking,
I try to never do that.
Right. I know you
Right.
don't.
Yeah.
But even if you're saying, say, fibromyalgia, okay, I think that it's what's called a functional disorder. And I believe functional is real. Some people use functional to mean psychosomatic, meaning it's all in your head because they don't understand. And we talked about this, guys.
Callback to our previous
Yes,
podcast.
yes, we
about
did an
functional
episode on this.
disorders.
And I just did fibro.
Yeah.
Fibro, which should be coming out before yours, with Dr. Michael Lenz, who has a whole podcast entitled Conquering Your Fibromyalgia. And he talks about all of these kind of undifferentiated disorders. But even if you say that, you have to be very careful because it's easy to miss a diagnosis that might take more time to find. On the one hand, you don't want to overwork up. On the other hand, you don't want to
that's, I think, the importance of longitudinal care over time.
Right.
That in longitudinal relationships, patterns emerge, right? And the clinical history becomes more clear. Right. And you may not get an answer now, but you may get an answer in 6 months. Right.
Absolutely.
And so your essential responsibility is to ensure the safety of the patient fundamentally.
So I'm really glad that we're talking about what you're calling undifferentiated illness, which is what I'm calling the fibromyalgia, chronic fatigue, long COVID, chronic Lyme, spectrum of disorders. I think it's really important because I think that in a model where you have very short visits with your primary care, that's a really hard patient. They call them heart sink patients for a reason. But it sounds like with your model that could work out better. So I'd love to hear some more of your thoughts on that.
Well, I mean, a lot of what I do is actually so my televisit sessions, which I do once or twice a week for a half day, are 20-minute visits. And so they're shorter, and sometimes I'll overbook myself a little, but not that much. And that's often good for like the longitudinal follow-up, right? I did an in-person visit with a thorough physical exam. I maybe got some labs, right? And then, I can book many repeat televisits with somebody for the very necessary talking and processing and being with, until we feel like we're getting somewhere.
I think that's fantastic. And I think that unfortunately, the model of doing tests, finding that they're normal, and then saying, oh, it's functional, which is, can be used semantically to mean it's psychosomatic, which means it's all in your head. And then they send to a psychiatrist. And my understanding is it's more common to have emotional issues from improperly treated illness than that,
than the reverse.
Exactly.
Yeah.
Right.
I feel that to be true in my heart. I think that a lot of what we provide is actually therapeutic presence. And I participate in something called a Ballant group, which is actually something. I actually have 2 Ballant groups. One through my work and one independently. And Ballant group is something that's a feature of family medicine residency training, where you kind of work through emotionally challenging cases with other family physicians. And someone said to me once I think maybe in residency, that like, when there is no medicine, you are the medicine.
Wow.
Right. So that this idea of sometimes all you can really do is hold space with someone and be like therapeutically present. Right.
But that's huge. I mean, these people often go on a journey where nobody believes them.
Right.
You're not only suffering, but you're being dismissed.
Yeah. So I hope that doesn't happen to my patients. Like, I hope that they feel heard and validated.
I'm sure that they do. Do you do advocacy in any way for your patients?
I mean, like on an informal level 100 times a day, but like, you mean like by going to the State House or something? Like,
No, I'm sorry. I was very unclear with that. I meant, do you call up specialists and say, I don't.
Like all the time. Like usually it happens in my chart, not my chart, in our like Epic in-basket system, right? This is like the benefit of like an integrated healthcare system. My cardiologist, neurologist, whatever, is just like an electronic in-basket message away, right? So I do a lot of that clarifying and thinking and talking, asynchronously.
Wait a second. All your specialists are integrated in?
Not all of them, but a good number of them.
Wow.
Right. So we have integrated ENT, integrated OBGYN, integrated cardiology, neurology, and like it's like a finite number of specialists per department, like 3 or 4 usually. But the vast majority of things we can get our specialists, like either like phone call access page if it's urgent, or if it can be done asynchronously, we can message them.
That's fantastic.
It is phenomenal. It is such a privilege. And then for ones that need to go to our tertiary care centers, we usually have access either through Epic or through like another little portal widget that we have with our other major tertiary care systems in the area.
That is awesome. I also meant from like a school district standpoint, like I do that, I will call the school. I will sometimes go to meetings.
Yeah, I do that also.
You do it all.
Yeah. Like I don't have to do it. Like I feel like I do a lot of like writing. I feel like maybe this is just a slice of sort of time. I think I've done that probably like 6 or 7 times, like actually like been in any kind of multidisciplinary meeting. But I've made a lot of phone calls to schools and it's also hard because of HIPAA. You have to get releases. You have to get, everyone has to be on board. I've written a lot of letters in support of evaluation. I've, sort of used my experience as a parent of neurodiverse kids to help families navigate the evaluation, IEP, et cetera, process. Right. So, I mean, there's that.
Right. And I think if you're a parent, right, you have a whole other level of knowledge that somebody who hasn't lived it doesn't know.
Right. Right. Particularly like, I mean, going through an IEP process is like something that you can't, I essentially did that for the first time as a resident, and it was basically a second residency.
Right.
So much work. But like so valuable and like possibly more valuable than some stuff I did learn in residency, Right,
because the services our patient gets, right? It's not just what we do in the office. It's also what they're getting in the community.
Right.
So that's really important.
Yeah, but I certainly don't do that alone. And I certainly have a very lovely team of people who help with that and do a lot of it, in fact.
That's huge. That's huge. I mean, I do this on my own time. I don't do this, paid for by work because it wouldn't pay.
Mm-hmm.
And that's a whole separate thing.
I feel like I feel like I don't even think about it being on my own time, although I do try to maintain some kind of work-life differentiation. Right. But I feel like I'm always thinking about my patients. So
that leads me to not let you forget the question, who would be a good fit for this?
I think you have to be able to be satisfied with being a little bit of everything.
Mm-hmm.
Right. And I feel like there are some people who have a burning desire to know everything there is about idiopathic pulmonary fibrosis. They want to be the world expert in one disease. You're not going to do well in family medicine if you do that. And you have to really sort of be fascinated by this intellectual curiosity about families, right, and their lives, people's lives. You have to be a little bit of a yenta. But of course, in a very discreet way, not in that you love sharing knowledge about people, because that's not what doctors do. But you have to love to know about people, right? That has to be satisfying to you to know about somebody and their life and know that you've helped them in some way.
Absolutely. I think that's a great answer. So I want to thank you so much for doing this with me. I'm really excited to have had this chance to talk about your field, which I really did not know so much about. I'm jealous of a lot of the things you have, honestly.
Also, the views represented in this podcast are my own. It should not be construed the Gansa picture of family medicine, right?
Right.
There's as many different kinds of family doctors as there are family doctors. You've met a family doctor, you've met one family doctor.
Right, right. Alluding to, if you met one person on the spectrum, you've met one person on the spectrum.
Or
another talk.
It's a snow clone, you've met one person doing anything,
Right. Right. But I think also it's important to say that this is your very specific setup where you really have a lot of ideal things set up.
Right. Except for wearing comfortable footwear and driving Subarus, which is all family doctors.
Oh, yeah.
That was a joke, actually.
Oh.
How do you clear out the buffet line at a family medicine conference? Will the owner of a green Subaru Outback please move your car?
But otherwise, you're very diverse, right?
Otherwise, we're very diverse.
So I want to thank you so much for doing this with me and let you go back to your Instant Pot chicken soup.
Yeah, sounds good. All right. Thanks so much.
Have a good Shabbos. Thank you.
Good Shabbos. Bye.
Too.
Thanks for listening to the JOMA Preventative Health Podcast. If you've enjoyed this, please rate and review us on Apple Podcasts and share this with your friends. For more information, check out our Instagram at JOMA_org. Check out our website, www.joma.org, that's JOWMA.org, or email us at health@joma.org.